Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Treating Palatopharyngeal Inadequacy, a Cooperative Approach. With Dr. Brian R. Lang, Chairman, Department of Complete Denture, University of Michigan School of Dentistry, and Dr. H. Harlan Bloomer, Professor of Speech Pathology in the Department of Physical Medicine and Rehabilitation and Director of the Speech Clinic.
The speech rehabilitation of patients who have palatal incompetence as a result of paralysis poses special problems for the speech pathologist. This is particularly true when the palatal weakness cannot be relieved by exercise. Then the treatment of choice must be made between palatal surgery or the construction of a lift appliance. A few years ago, the late Dr. Paul Gibbons and I designed the first lift appliance for a young man who had suffered from bulbar polio. The appliance and its evaluation were first described in the Journal of Prosthetic Dentistry in 1958. Since then, many appliances have been constructed at the University of Michigan and elsewhere for the relief of the speech problems of patients who have palatal incompetence. Today, Dr. Lang and I are going to demonstrate for you the major considerations involved in the examination, treatment planning, and appliance design for construction of a lift appliance for a polio patient. Mr. Solars suffered an attack of polio several years ago and has worn a lift appliance for the past 3 years. He has recently had a new appliance constructed, and we will center our discussion around the construction of this new appliance.
During the clinical examination of our patient, we are concerned with gathering information about several areas. We'd like to know about the patient's existing health from the medical viewpoint. We are interested in the status of his remaining natural teeth and the supporting tissues. We are interested in gathering additional models and radiographs for further clinical studies. With this, we are also interested in some of the areas that Dr. Bloomer is going to examine as far as the patient's present speech productivity and things of that nature. We might start off by looking at some of those things, Dr. Bloomer.
Well, the first thing that we would be interested in would be just the general speech behavior of the patient. Would you count up to 10 for us?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now, there do not seem to be articulatory errors. Obviously, the voice is hypernasal. But to check articulation a little bit further, let's have him read this little mini test of speech articulation.
We bought my father 2 new sun lamps. You should choose a red coat hanger.
Again, we see that there's no obvious articulatory error present. The sentences are designed to test each of the consonant positions, not each consonant, but bilabial sounds, labial dentals, and so forth, so that I don't see any obvious articulatory error. There is persistent hypernasality, however, and his voice quality shows some effects of the fact that the vocal folds are not closing completely. Say, ah. So he can produce clear phonation, but does not characteristically do so. Now, one of the things that we want to check with reference to palate function, before we go further in testing voice, is to see whether or not, under maximum effort, he can blow this ball to the top. This is a little graduated scale. Now you hold your nose first and blow the ball to the top so I can adjust this. Blow it clear up. Okay, that's enough. Now see if you can do that without holding your nose. Fine. He is able to make the closure complete when the pneumatic pressure from below blows it up. Let's see if you can do this on inhalation now. First of all, hold your nose and draw the air to the top. Okay. Now do it without holding your nose. Well, he is able to do that. He was not able to do that when we first tested him at all. Now let's try some of these other things. Let's get, although these are relatively crude tests that I'm doing here, they're clinically useful for us. I want you to say zippers are easy to close.
Zippers are easy to close.
And you see that you're getting nasal emission constantly, although a person should not be able to do, or should not get this nasal emission when he does that. Now say, go get a bigger egg.
Go get a bigger egg.
All right. I simply want to have that as a record in case we are able to construct an appliance successfully for him. Now, one other thing that is of interest to me, I want you to say, ah. Let me just check the nasal air on that again, once more. And so we know that there's nasal emission. Now I want you to say the high, ah. We get some clouding, but very little. So he's able to use his palate effectively with a high pitch. However, of course, he couldn't talk this way all the time. So this is a palatal function which is interesting to demonstrate, but would not be really useful to him. I think these are the things that I wanted to bring out right now.
I think we can, using the mouth mirror, we might go into the oral cavity at this point and look at some of the existing structures, as particularly the soft palate, as it elevates during phonation, and see what control he has and whether we can reposition the soft palate and possibly alter the degree of nasality. Mr. Solars, can you open quite wide for us? Now, Mr. Solars, give us an ah, please. There's a little movement of the soft palate there. Now, change the pitch in that and say, that's it. Well, there's quite a bit of different movement there.
That's what we heard a while ago.
Once more, give us another ah. We get some movement, then it relapses, and then it just holds there. The other thing that I think it points out quite nicely, if I take the mirror here, that I can displace the soft palate with this mirror quite easily, and I don't receive any great resistance on the handle here of the mirror. Again, let's have Mr. Solars elicit the vowel ah, and then we'll elevate the soft palate and see if we change the nasality. Mr. Solars, would you give us another ah, please? Okay. Now we'll elevate the soft palate again.
Okay, one thing further that I'd like to demonstrate is a little difference in the diadical kinetic pattern, which I've observed in his case, and which may have some effect on the appliance. Mr. Solars, I'd like to have you say ta-ta-ta-ta-ta-ta-ta-ta as fast as you can go. Now I want to turn this a little bit to the right. Now do the same thing. Can you tip your head a little higher? Okay. Now I want you to say la 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 la. What I want to demonstrate is that forward thrusting pattern and the fact that he has difficulty in inhibiting his jaw movement. Try that again. La 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 la. Now can you inhibit the jaw movement when you do that? Try it again. Keep the jaw still. He can do it. Sometimes patients cannot if they've had any kind of nerve damage. Now, one further thing that I would like to Check is a list of words that we use for speech intelligibility. I won't have him read the whole list, but just read the first 10 of those, if you will, Mr. Solars, rather slowly.
Not, say, mop, reel, cake, paw, vial, heat, look, kill.
Thank you. There are 50 of those words. They're rhyming words. We play them to listeners, and they are to judge whether they can hear them rightly or not, and this is one way of getting an intelligibility test. So I thought we'd check him before and after he gets his appliance. So we'll have some objective evidence of the effect of the appliance.
I think at this point we should go ahead and secure our impressions for the study models and go ahead and complete the detailed dental examination and see whether or not we will need to place any restorations and essentially complete the dental part of the examination.
Good.
From the dental point of view, the gathering of the diagnostic information that we performed in the clinical environment results in us following a particular treatment plan sequence. That sequence usually results in rendering the patient's remaining natural teeth in a state of health, evaluation of the supporting tissues, and then progressing from that point onto the prosthetic considerations. We have before us here a model of Mr. Solar's teeth in occlusion, and I think it points out some of the problems that one is faced with in the prosthetic considerations. The closeness of the bite, as you see here, this will present problems when we approach the proper undercut of this tooth for our clasping. Likewise, our indirect retainer, which we will be placing in this tooth, these are considerations we'll have to make clinically and create some sort of clearance so that the clasps can come through the bite. Likewise, on this side, you see a similar situation exists. We have a little better relationship back in this molar region, but up in the first bicuspid, we'll have to do some tooth modification in order to clear that bite.
Now, you think you'll have no real problems of retention, though?
No, I don't at this point. Nothing that will necessitate at least modifying the form of the existing natural tooth. Nothing drastic, anyway. This model is a little bit different than the conventional model that one secures in making an impression and then pouring the model, in that it has a section in the pharyngeal region which indicates a new position for the soft palate. Some other things that we should talk a little bit about, and that would be the configuration for the supporting framework as it comes across the hard palate in the posterior region here, and also up in this anterior area where the rugae pattern might be. We've talked in the past about the problems one can create for themselves by not designing the framework properties, as it might interfere with the rugae and articulation errors and things of that noise. I wonder if you might want to comment on that.
Well, I was curious to know whether you would need to put any coverage here because, as you say, sometimes that does interfere with speech articulation. And,
well, we will be covering the area. However, it will be rather thin and in two planes covering this section of the hard palate and only back to approximately this region in here. Then the mid palate will be open and will go on. I indicated that the position of the soft palate, as is designated here, is at an approximate height, and we determined this, as you recall, when we looked at the patient's radiographs and also when we elevated the palate clinically. And maybe we should turn and look at those x-rays at this time and see if we can't learn a little more about our patient. The first view shows the patient at rest, and I think this demonstrates quite nicely the position of the posterior pharyngeal wall and the soft palate, with the space between the posterior pharyngeal wall and the soft palate adequately demonstrated. This other view is with the patient eliciting the A, vowel A as in ah, and again you can see the posterior pharyngeal wall, the position of the tongue and the soft palate, and the residual lumen that is still present.
Yeah, it's evident that there has been very little movement there of the palate for that phonation.
Right. If we change the radiograph of rest and replace it with additional views, in this situation the radiograph eliciting a high vowel A as in ah, we get an entirely different picture of the position of the soft palate. And also he seems to be changing his head position here a little bit too. But you can see here is again the shadow of the posterior pharyngeal wall, and this is of course the shadow of the soft palate. There still seems to be a little bit of a gap there though.
There's still an opening, and he was still hypernasal, but it was interesting to see how much change took place. That was really a very high, almost a falsetto that he was producing.
And if we look back at our original radiograph that is listing the regular vowel A as in ah, there's quite a difference between the two.
Yeah.
Again, let me replace this view of the high vowel A with a view of the patient now eliciting the vowel E. And again, we have a completely different configuration of the relationship of the posterior pharyngeal wall to the residual soft palate.
E is supposed to elicit greater elevation of the soft palate than any other vowel, but as you can see in his case, it didn't do very much for him. He was still quite hypernasal.
We have two additional cephalograms I think would be interesting to look at. The first demonstrates the patient blowing, and the second, which we can compare with the first, is the patient producing a sustained S. Let me just move this over a little bit for us. There we are. And again, we have an entirely different picture here.
Complete occlusion.
Yes. Soft palate is way in its elevated position and closing off. Comparing this with the sustained S, again, we have almost complete closure, but it looks as though there possibly is some leakage, at least if not in the anterior-posterior direction, maybe laterally or something.
I think there's complete closure, and I think that we demonstrated that in the chair when we put the mirror under his nostrils. This is interesting that he's able to make the complete closure, but I think we're pretty well assured, and we'll see on the video fluoroscopy sequences of whether this is true or not, but I don't think he can sustain or use that elevation in speech at all.
I have one other view that I think is worth looking at. It's, as you recall, we took and elevated the soft palate with the tongue blade. And this is a cephalogram which demonstrates that same repositioning of the soft palate. Here is the tongue blade, and of course we've positioned the soft palate in this configuration in relationship to the posterior pharyngeal wall. You'll recall we were able to position that tissue and did not meet any great resistance. So, and of course his eliciting of the vowel at that time too indicated that we were decreasing his nasality.
And of course, when that was done, I always listened to see what change in voice quality takes place, and he was not hypernasal at all in this instance.
Well, these are static films, as you know. They're showing positional relationships during phonation and during positioning of tissues. This does not give us the total picture, though, during connected speech and continuous movement of these structures. So maybe this time we should review the cines and see if we can't shed some more light on our patient's problem.
It'll be interesting to see those for comparison. Will you count from 1 to 10? So
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now the sentences.
We bought my father 2 new sun lamps. You should choose a red coat hanger. Bobby pulled down 2 go-karts. The thing is very full. Send his shoe measure to Charlie Jones. Why won't you let her run? Mary never sang. Zippers are easy to close.
Well, as we anticipated, the cines do show us information, or provide information for us that we didn't get from the lateral stills. He has a good deal of control of the palate, but not sufficient to make complete palatopharyngeal closure, and I think you can hear from the voice quality that this is not really adequate speech quality for him. Incidentally, I think that movement was not apparent when we first saw him, when we began our treatment program. He evidently has responded to the appliance that he's been wearing for the past period of time.
There's a lot more mobility there than originally.
No question about it in my mind.
Maybe we should return to the clinic now and put the appliance in and see just what progress Mr. Solers has made over the past few years, and demonstrate again some of the same information we gathered in the CINEs and in the cephalograms.
I think we can do that, and then we'll come back to the CINEs again and see how he performs there with the appliance in place.
We have completed construction of the Palatal Lift appliance, and I thought we might look at some of the aspects of that prosthesis. It comes in two parts: the dental section here that's called the palatal maxillary segment that attaches by way of the clasps to the remaining natural teeth, and then this posterior extension, or the lift part, which positions the soft palate. Perhaps before we have Mr. Solers insert the appliance, we might have him say a few sentences for us to give us some baseline to compare.
Those two sentences that have no nasal sounds in them. Zippers are easy to close.
Zippers are easy to close.
Go get a bigger egg.
Go get a bigger egg.
Now after he puts those in, we'll say the same sentences again. Now, zippers are easy to close.
Zippers are easy to close. Go get a bigger egg.
Right.
Yes, there's quite a change there.
Maybe
we should have him perform on the blowing and the sucking test and see if that has been improved.
Well, yes, we can do that very easily. Let's check the blowing now. Remember, we did this before, and he was able to produce 100%. There we have it again. Okay. Now this time I'm going to change the position, and you're going to inhale. We'll see if he does it any more easily than he did before. Oh, he does much more easily. He was able to do that, but it was quite an effort for him before. Now with the mirror, I want to check just to see whether we're effectively controlling palatopharyngeal closure. First of all, we'll see if he's able to demonstrate breathing. He has got clouding, so we know he has no blockage at that point. Now say zippers are easy to close.
Zippers are easy to close.
He gets a very slight emission. Go get a bigger egg.
Go get a bigger egg.
And there he was successful in saying it without any emission at all. We ask you to read these sentences before, and let's see if they sound any more intelligible this time. For these words, these are not sentences.
Not, say, mop, reel, cake, paw, vial, heat, look, kill.
Thank you. Well, I think we've been able to demonstrate that the appliance does alter his speech behavior effectively.
Maybe we should look and see the appliance in position and what's actually doing to the soft palate. Lean your head right back for me. Open real wide, please. You can see that the soft palate is elevated up and back in the approximate position with the posterior pharyngeal wall. Mr. Solers, would you say ah for us again, please?
Ah.
It's as though we're getting a slight amount of movement of the palate away from the lift.
Right.
Again, ah.
Ah.
Now would you also change the pitch of the ah? Again, we have some additional movement there. All in all, it has elevated the soft palate, I think, in the position we desire. Mr. Solers also demonstrates another situation that I think is worthy of note, and that is the way he holds his head during work and things of that nature while talking. It does affect his speech, and I think we might talk a little bit about that.
Well, I think we can show that by means of the mirror. Will you put your head in the position that you characteristically use and say the sentences, zippers are easy to close and go get a bigger egg.
Zippers are easy to close.
Now, go get a bigger egg.
Go get a bigger egg.
Now, put your head back in a proper position for the appliance, and let's do the same thing.
Zippers are easy to close. Go get a bigger egg.
So
Complete closure there?
yes, we get an effective use of the palate.
Mr. Solers also commented to us about the tiredness, the fatigue aspect of his speech and what effect the appliance has on that. I think maybe we might have him elicit in his own words a little bit about that. Mr. Solers, you indicated at one time that without wearing the appliance, after a period of time, you were very, very tired. Yes. And do you find that this has improved now with the appliance, and if so, how?
Yeah, this is the biggest factor that I've noticed is the lessening of the strain and the fatigue, particularly at the end of the day with the appliance. Without it, I can't hardly talk at all at the end of the day.
Do you do quite a bit of talking in your work?
Yes, I do. Yes, that's my job, talking.
Well, I think we might gather some additional information at this time. Repeat the cines we took without the appliance, and again the cephalogram series to evaluate what effect we are having with the appliance in position as far as palatopharyngeal closure is concerned.
Right.
Since our recent clinical visit with Mr. Solers, we have gathered some additional information, particularly in the form of radiographs and some cines. And I know you've gathered some additional speech examinations. I think it might be appropriate if we reviewed and summarized some of his accomplishments.
In our speech evaluation, the last one with the appliance in place, we administered the same tests that we had administered prior to the making of the appliance. We saw that with the mini test of articulation, he did not have any obvious articulatory errors. We see that there is considerable change in voice quality, although there is occasionally some hypernasality, and we see that there is from time to time still some nasal leakage, as we saw on the nasal mirror. On the blowing tests, however, I think we were able to demonstrate effectively that even on inhalation now, with the assistance of the appliance, he's able to make a 100% closure. The most interesting thing, I think, that's come out of the speech testing is the results of the intelligibility testing. You will remember that we administered the Fairbanks rhymes tests. This was a 50-word sequence of rhyming words, and these were then played to listeners to make a decision as to whether they heard the word correctly or not. These are objectively scored. Without the appliance, he achieved a score of 92.48. That means that he had 94 listener errors. With the appliance, he achieved a score of 98.24. dropping his listener errors to 22. Now, the normal average is 99.19, so he's very close to a normal speaker. And I think this is perhaps the most objective means we have at the present time of evaluating articulation from the standpoint of the listener.
Well, the radiographs that we took with the appliance in position, they also point out some unusual situations taking place, and I think we might look at some of those cephalograms and see what actually is happening. This is the film that was taken with the, as you can see, with the appliance in position, with the palate in the elevated relationship to, again, the posterior pharyngeal wall. Now, he is at rest at this point, of course, not producing any sort of a sound. And if we, as we can see, there's adequate space in this vicinity for comfortable nasal breathing. If we then compare this radiograph with the one in which he is now eliciting the vowel A as in ah, we see that there is some slight change, possibly posterior pharyngeal wall movement here to close the lumen, although this is still open and might be indicative of the nasal leakage that we saw clinically.
He's still a little hypernasal. He was when that radiograph was made.
Now, he does some other interesting things here. If we change the radiograph of rest for A as in ah, and he changes the pitch of the A, and again now you see a completely different situation here. There actually is a closure. Whether or not this is again change in position of the head or change of the posterior pharyngeal wall or just what, I'm not absolutely certain. But anyway, there is closure taking place here, as we did not see, however, when he listed the plain ah.
The quality of the voice enunciated when he made that film would indicate that it was not just head position change, but that the palate, the tissues actually moved and closed off the nasopharynx.
Now this this next radiograph is the enunciation of the E, and again you see a little different relationship of the contours of the soft palate in this elevated position by the plastic extension here in relationship to the pharyngeal wall. Now there is some
further narrowing.
Yes, right. Two other radiographs that we did secure that I think we might want to compare to one another are this this view here, which is a sustained S, and I think we can compare that quite nicely with this radiograph here, which is the blowing situation. If you look rather closely here, you see this is the plastic extension of the appliance, and this is the elevated position of the soft palate. Again, he is attaining closure here to the posterior pharyngeal wall. The interesting thing is this slight little shadow that we see on the upper side of the plastic, which indicates that the palate is moving away from the plastic extension. Now looking and paying attention to this, if you view this other radiograph, you see that this space in here is quite pronounced and rather large as compared to the previous one. The palate is in a little different position, and of course he is closing off quite nicely.
Well, the pneumatic pressure and the blowing, you see, he's blowing against resistance. In fact, he had his thumb in his mouth in order to produce that, and this is what you have to do in order to get that kind of film in most patients.
Now, I'd like to also go back and to review two films, the original A as in ah, and compare that with a head position. In other words, he's producing the same sound, but he is changing his head relationship to the posterior spine area in the complete different arrangement that we see in the soft palate region. Here, as you can see, he's changed his head position completely and is definitely getting closure here, where in the original radiograph that we viewed, where he was assuming a restful position for him, he does not have the closure that we would like to see. This might be a training situation that could be improved.
I think we'll see that demonstrated again on the cines.
Maybe at this time we should go and look at those cines and again compare them to our previously taken ones.
We'll make the same series with the operator in place, so as to count from 1 to 10.
All right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now the sentences.
We bought my father 2 new sun lamps. You should choose a red coat hanger. Bobby pulled down 2 go-karts. The thing is very full. Send his shoe measure to Charlie Jones. Why won't you let her run? Mary never sang. Zippers are easy to close.
Now I want you to put your head forward and say, ah.
Ah.
That's all right. Now bring your head down. Now we have to. Okay, now. I'll say zippers are easy to close. Keep your head back.
Zippers are easy to close.
We bought my father 2 new sun lamps.
We bought my father 2 new sun lamps.
Say that again and keep your head back.
We bought my father 2 new sun lamps.
I think the fluoroscopic radiographs further emphasize some of the things you demonstrated with Mr. Solars clinically. To me, anyway, it certainly indicated that our level of improvement is not exactly what we had thought, and that certainly we could help him with maybe an additional appliance modification.
Yes, I agree. I think it shows us maybe three things that are of importance here. One is that we did not quite achieve the perfection that we were aiming for, but we think that that's still possible. Mm-hmm. Secondly, that there is possibility of further modification of the appliance itself, but perhaps most important of all, Mr. Solars is going to have to learn himself to make effective use of the appliance, whatever appliance is placed in his mouth.
I think also the last area there in the films where he changed his head position was rather interesting. Perhaps some additional training in that area might be very beneficial.
I think that taught us something. I don't believe we've observed that before in any patient that we've dealt with, and we'll be on the lookout for that possibility hereafter. By way of summary, I think that we might point out that when we started out to give this demonstration, we said we would examine the patient, would offer a treatment plan, and would pursue its execution. We have done this. You have seen, I hope, a marked improvement in his speech. There are obviously further things that can be done. We have to regard this kind of a treatment program as an ongoing process, which is possible to modify from time to time. This is one of the advantages of the procedure. We think that we have reached a point of stabilization at which we can now terminate our present treatment.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.